We'll just give it about 30 seconds to allow Maria to let everyone come in. Thanks, Maria. Well, welcome everyone to the first OC3PR for 2023. I know many are facing countless challenges, but I'm going to let you in on a secret. 2023 is going to be the year when things start to get better. Maybe I'm naive, maybe I'm still on vacation in my mind, but I do believe we will see a shift to the better this year. The Roaring 20s version 2.0 is about to begin. With that statement of optimism, we're going to hear about strategies on how to make the best of the current situation in regards to health human resources, an issue I know all centers are currently facing. You'll want to listen to this one. Ontario's Critical Care Clinical Practice Rounds, or OC3PR for short, is the bi-monthly educational series sponsored by Critical Care Services Ontario. Its mandate being to help provide the skills and knowledge to health professionals, be they medical providers or administrators, all of us who help ensure that the care provided to the critically ill is that of the highest possible standard. All of the previous OC through PRs are available from either the CCSO website, or you can easily find them on their YouTube channel. For today's session, you'll have the opportunity again to submit questions or comments via the Zoom chat feature. Just send them to the people named Q&A for question and answer. Today's questions are being fielded by Ms. Michelle Stevens and Ms. Crystal Pitfield, both members of the OC3PR Executive Committee. As always, we ask you to please keep yourself muted for the presentation. I'm sure that all of you are facing staffing challenges. Burnout and failing resiliency of your staff has certainly contributed to shortages, be it from increased sick time or from problems with recruitment and staff retention. The finite number of health professionals has certainly contributed to the problem, with sites often purging professionals from nearby facilities. This disruption is significant, but the impact on morale, staff burnout, and interpersonal relationships has been devastating. How can we begin to address these issues? Recognizing that solutions will likely differ depending on the size and nature of the facility, along with the variability of cultures. How to begin to address these issues is a daunting task, to say the least. Fortunately, we have two speakers today that will help us begin the process. Ms. Stephanie Pearsall is the current Vice President of Clinical Programs and Chief Nursing Executive at Cambridge Memorial Hospital. She is also the Administrative Lead for Critical Care for the Waterloo-Wellington subregion. She has extensive leadership experience across most clinical platforms in various levels of facilities, including rural, community, and academic settings. Stephanie believes that building strong relationships is essential in designing integrated systems of care. Presenting with her today is Ms. Shannon Maier, who is the Senior Director of Patient Services at Guelph General Hospital. She is a nurse with clinical experience in women's and children's care, medicine, intensive care, and emergency medicine. She has held operational and executive leadership positions in small and rural, medium and large community hospitals. She received her master's in quality improvement and patient safety from the University of Toronto. She is passionate about applying improvement science to solve complex problems, to transform culture and practice, all to achieve measurable improvements in all elements of the quadruple aim. Our objectives today are, as usual, ambitious. We hope to identify strategies that can be used to improve and support critical care staffing, how to identify additional strategies or resources that may be helpful to support staff education and retention will be discussed. And finally, how to begin to develop initiatives that can be utilized to support staff well-being and to develop long-term retention strategies. Stephanie and Shannon, thank you both for agreeing to present with us today. I look forward to the presentation and the discussion afterwards. I'll pass it over to you both now.
Thank you, Dave. As you said, I'm Shannon Maier. I'm really honored to be here today talking about this really important subject You'll see our objectives on the next slide. What I'll say is Stephanie and I have worked alongside of each other in the system for a very long time. And we also are long time ago critical care nurses, so we care deeply about the health human resource scenario we find ourselves in. Really, we're going to talk to you about the Waterloo-Wellington regional approach and making the best of the current situation, but want to leave you with some thinking on our near and far next steps and dreams for the future. Overall, we really want to talk about shifting our mindset. Over to you, Stephanie.
Next slide, please. So thanks for having us today. Really happy to be here. We are going to sort of focus right now on the medium-sized community context. I do think are transferable learnings across all sectors in regards to this. And just to give you a bit of a flavor, the Waterloo-Wellington subregion is comprised of 7 hospitals, and they're from large community to small rural hospitals across our sort of really large catchment area. We have St. Mary's General Hospital, who is a cardiac program, has a hub and spoke model that really supports patients outside the boundaries of the Waterloo-Wellington region. We have Grand River Hospital, that is our largest hospital in our region, regional oncology, regional stroke site, orthopedics, has some Schedule I mental health beds, and 2 campuses of care, including a more post-acute campus as well. Guelph General is a developing level 3 trauma site, vascular site of excellence, as well as bariatrics, telestroke. And at Cambridge, we are Schedule I mental health. We have some Schedule I mental health beds, critical care, and a regional liver health center. Groves Memorial Community Hospital is in Ferguson. We have 2 smaller sites at Louise Marshall and Palmerston and District Hospital. It's kind of a sense of who we are. Together, we hold 57 level 3 critical care beds and 29 level 2. We do have some cardiovascular ICU beds at St. Mary's, as well as some CCU beds there as well. We don't have a tertiary site within our region. So what that means really is that we don't have the same volume of learners that some of our larger sites will see, as well as project resources and supports really that you often can expect to find that definitely bolster teams in that sort of academic setting. Our units are small to mid-size from a critical care perspective, and this nuances health human resources in a couple of ways. One, it really takes very little absence for us to vastly change risk to service delivery as well as quality of care. But on a positive note, what that introduces is that we're very nimble and we are very well connected to our teams. And if there is something new, when it comes to test of change and transformation, that's probably a little bit easier for us to operationalize. And it really leads well to team building, which I will tell you that we have relied heavily on in times of crisis throughout the last 3 years. We see all demographics of patients, from rural to large community. We have a large catchment, like I said, but we do rely heavily on our tertiary partners for some aspects of care. We are each other's employment competition, which we recognize, but we really have to be close, and we consider ourselves almost best friends in order to survive any sort of difficulties. And we are very, very committed to that. And you will hear that theme, I think, throughout our presentation. We are committed to providing, pretty much the same orientation and programming into our critical care units, so people aren't moving around. It's nuanced specifically to what the service we provide, but we really try to provide the same type of experience that you will see no matter where you go within our region. We have a flat organization, so our org structures aren't that big. So it does make it a little easier for relationship building. Next slide, please. You will see shared pressures. This will be of no surprise to any of you that are on the call. And when we think about novice workforce and flow barriers, vacancy rates, lack of RNs, and agency and untrained critical care staff. And, for us in this region, we were really new to the agency game. The agency staff was not something prior to the pandemic that many of us had really dabbled in. We would have the odd agency nurse here and there, but it wasn't a big part of our workforce, which we find ourselves now. And even our rural sites are employing agency nurses. So this is very unique for us and very, very different. We committed to really trying to stay within the confines of a collective agreement language when it came to staffing. We weren't always successful. Some of us stepped out at times when staffing was very, very, very critical, but we really tried to stay true, and because we didn't want to create an area of risk to another hospital within our region. Pediatrics for us was something that was very new, pediatrics coming into adult ICUs. We are the one region that does not have a pediatric intensive care unit. And so that was very new, bringing, even for our intensivists, bringing 14-year-olds into ICUs it took a lot of change management and a lot of really, really positive support to do that. Next slide, please. So our regional approach, and here is our Cambridge team in one of our new rooms, and we have really, really, really tried to stay connected. So we find ourselves now in the third year of the pandemic, with staffing actually being a bigger problem than COVID. And COVID may have led to the staffing issues, but health human resources is a theme provincially. What we have done is we have been really thoughtful and really intentional about building relationships across all of our hospitals. And what we have done is that we have set up a weekly touch point. And this is from the early days in the pandemic. And it was grounded really in a culture of inclusivity. There was no hierarchy. It was really about efficiency, and it was about risk management. Who sits at that table? That's all the directors of the critical care programs. The physician leads for all hospitals are invited. They don't always come, but myself as the executive, the admin lead, Dr. Frank Reinders as a medical lead is there each week. We have Marion from CCSO, Nisha prior to Marion, and we have Matt Bird from Critical. And we are committed each week. We've actually just moved to biweekly to come together. Shannon and her predecessor before her sits at CCWAC, and it's a connection to a broader provincial and the CCSO funding initiatives, which we fully take advantage of at every single opportunity. What this has done is has allowed the team to really build out an efficient way to respond to both bed pressures and staffing pressures. And we continuously smooth across our region. We look at our critical care platform within WW as one platform. So we smooth, not just based on patient occupancy, but if one unit is critically staffed, we will come together quickly and we will try to sort out how do we move patients around so they get the best care possible. When it's bumpy, we know who to call. We're very committed. It is a text and we come together very fast. And really it's about relationship building. And I would say on a lot of days, it's probably about moral support. The connection and the commitment is something in the region, I believe, that really has helped leaders battle their own burnout. And we will talk more about moral distress and burnout throughout the presentation. But what we wanted was to build an environment where you weren't alone and that you didn't have to flounder, that there was somebody there to catch you and to provide the support that you needed. Now we're looking at the future. What does that look like? And that's sort of the topic that we're talking about today. And how do we make the best of our health human resource situation? And we want to really approach this with a regional focus the way that we did earlier in the pandemic. Over to you, Shannon.
Thank you, Stephanie. We can flip the slide. I am not going to spend a lot of time on the actual slide, but just to say over the last few years, there's some of the strategies that have been put into place in service of our patients to maintain service. And at sometimes it was really around keeping the wheels on the bus. And this is kind of where we find ourselves now. From a recruitment perspective, this probably looks very similar to others across this call. Optimizing funding for IENs and externs, critical care nurse funding, working with our partners in academia, looking forward to regional educators in the adult critical care space. You'll see I've highlighted that as something new that's coming, and adding additional supports that traditionally weren't part of the ICU landscape through RPNs and PSWs, of course, working closely with our labor relations partners on relationships and thinking a little bit differently about how we look after people. I did want to focus for a minute on our people, peer support, increasing funding, well-being initiatives. I think these are corporate things that we're all looking at across the province, really. We hear about this all the time in our own hospitals, and I hear it from my colleagues. But something that was a bit of an aha moment, or for my sport friend Stephanie, I'll say the TSN turning point for me was thinking about Code Lavender, which is something that's been brought to my attention recently, and some organizations looking to put this into place as an emergency code to respond to employee crisis. I just ask that you take a minute to just really reflect on what that means. And for me, I thought, here we are in a critical care environment, looking after our sickest, most vulnerable patients, some would say, highest level of tech and machinery, communications, very high risk environment. And we've got so many people breaking down in healthcare that we've actually had to contemplate an emergency code. So this is the kind of thing as a leader that I will say I lose sleep over, and working through this presentation actually helped us think a little bit differently about what the future could or should look like in terms of looking after our teams and building towards a situation where we're retaining people and keeping folks healthy. If you want to go to the next slide, this is a little bit of a scrapbooking endeavor. You can see the rabbit hole in the middle. And if you really look into burnout right now, and just pre-pandemic also, a lot of this was really rising as World Health recognized burnout as an occupational phenomenon. There's lots of information about what it looks like to come through difficulty. And I'll be the first to say, I'll tell a little personal story here. That during the pandemic and leading through crisis was actually a really satisfying experience for me. It brought me close to the teams that I was leading in a different organization, and to my colleagues and to my patients. I love a complex problem, and as a learner and achiever, the pace was really good. I don't want to sugarcoat that though, because it was hard work, and we were on call a lot. I'm sure many of the folks on this call remember those days. Or maybe not, you might have blocked some of this out. So I'm not trying to sugarcoat it, but it was positive for the most part to be part of that. So it was confusing for me when I found myself in 2021 actually Googling burnout and some of these resources. And mostly I noticed my brain seemed to be moving slower, and I was a little less motivated to do things I love, play my fiddle and read a book, socialize with my friends. And I was tired when I would get up in the morning. But being from an era in healthcare and leadership of never let them see you sweat, I think was the term we sometimes would share around. I kind of just poured myself into the day-to-day, even though I was really regularly identifying and supporting other people through their own burnout. So of course, I did what every learner does when they're tired, and I signed up for some coursework, which was actually excellent, a great way to recharge. But while I was making new friends at school, I also picked up COVID, which was the first time I'd had the infection. This was after, wave 306, and I was really tired. So I took the time off, I rested, I did the things, but I was really beat. And a couple weeks later, I was on the 403 and I bumped my car into the back of another car, which then bumped into another one and another one. And as I was sitting there, with the airbags off and that weird smoky stuff, of course, I'm getting a page, filtering around the car, I thought, shoot, I think I'm not myself, and my brain's maybe moving too fast. And that's actually the censored version of how I became aware that I had some burnout. So I did what we have been taught to do. The awareness helped me make a plan, balance myself, rest, do the things, music, vacation, some creativity. And really most healing for me came from my colleagues in the system and in the place that I worked, my leaders, leaders, and my friends and mentors, and support from actually some people on this call for sure. And then personal relationships. So I sort of proved to myself that we know how to manage burnout at the individual level. And I'm really passionate now about the collective and what are we doing to prevent this from happening and to avoid really the need for an emergency code for our people who we need to think about in terms of being leaders in this system as our duty to care for. And I think we need to look to positive psychology and resilience building models, lived experience, work like Mark Britnell's, which is really aimed at the global crisis, but really applicable to us in program and provincial planning, and think of a better way. You can flip the slide. Thank you. So this is a snapshot of the CCSO burnout and critical care. We are all just receiving these reports in the provincial report from 2022. I think we got some great feedback from our critical care teams on burnout in the provincial support. Not a lot of surprise for me, and I'm sure some of you, around the factors leading to burnout and what we're hearing our people say. I know everyone's really quite engaged with their teams. And when we huddle, we hear things like, I want to take time off, but I worry about my team. Working short, I worry about the safety of my patients, and mostly I just really want to give excellent care. And I think we all share that. And some strategies were outlined here for us, the top three being physical toll, introduction of support teams, and access to wellness activities. And much of our work to date has really been on bolstering the team, returning time to care at the bedside. I think that's kind of the saying, what is old is new again, but really at a corporate level, also looking at wellness. But what do we need to do to honor our duty to care as leaders in this space? And what Stephanie and I have been thinking about is, we need to really leverage our curiosity and creativity and innovate new models beyond these initiatives, where we're really thinking about creating environments where people leave their day-to-day as good or better than when they got there. That's your cue, Stephanie.
Yes, next slide, please. So how do we become curious and how do we become creative? And I think critical care environments in Ontario have been deeply rooted in tradition, and I know many of you know that. And we think about nurse-patient ratios and single and doubles and acuity and ratio models and all of those things. In the region of Waterloo, it's known as a bit of a tech hub, and we are currently working at a broader tech table to see how is there anything from an innovation in tech that can sort of superimpose over healthcare, and is there any commonalities that could make people have the best day, and what does that look like? And so I think, not only regionally, but probably provincially and nationally, we really need to get more curious and creative about what is the art of the possible. As a broader group of critical care leaders, many of which are at this table, I think that these are the things that we really, really need to consider if we want to develop environments that proactively prevent burnout. We are reactively responding to burnout, and we really need to proactively prevent. And, the Code Lavender is a very specific example of that, is this the point that we're at, that we're developing codes for employees that are in crisis? And it's actually really kind of unbelievable that this is where we find ourselves. We need to talk about new models of care and, that are grounded in practice and they're grounded in research, but really also looking at what are those non-traditional ways that we can think about. So how do we use volunteers, and how do we use families in the critical care space, and how do we support people to do things differently? I think we have to look at who's doing this well. And if it's not, within our own house and in our own region or province, is it national or is it international? We're not the well-resourced system that we thought we were. And I would argue that probably none of us ever thought that we were well-resourced. But what we did is that we were lean, and it really tied us to a specific notion of how we provide care. And that's what we're still reeling from. We know we will never go back to that. And so how do we move forward? And this is the place I believe that we are at. We have to work with our labor partners, and we are now tabling with our labor partners. What is a model of care look like? We get the rolling of the eyes, and here we go again with your new ideas and your new models. But we're really, really, really trying to invest. How do we engage labor partners? How do we engage staff? And really looking at being open and transparent in those conversations. It will involve clarity. What's your role? How do you practice at the top of your scope? And let's really stop talking about ratios, 1 to 2, 1 to 3. What does that look like? We need to really start studying productivity and patient safety. And it may look very, very different. Shannon referred to Mark Britnell, and he talks about care assistants. And they're really the people that that straddle both healthcare but social care across the continuum. And we've been looking at people and patients and really even staff and breaking it down into body parts and modeling care around that for a long time. I would say specifically in critical care, And we have to look at that. We have to look at it beyond what's the sum of their parts and look at it from a more holistic approach. How do we bring back compassion, right? How do we lead with compassion? And when I think about that, I think about what's the environment that needs to be fostered so people show up with kindness and positivity. And how do we enable critical care leaders to do that? And, you know, there's been a lot of focus on frontline staff, but what about the critical care manager who has really been sandwiched between what the staff need and then, you know, direction that they're getting maybe from a director or even higher? And what does that look like? And I know each of us have watched, you know, from the early days of the pandemic when critical care managers were working 12 and 14 hours a day and leaving in tears because they were trying to sort out how are we ever going to possibly staff this? And that's who we need to pay attention to and bring that compassion back. We have to go back to, you know, our days of nursing theory and think of Watson and the human caring theory and pair that with the perspective of today and technology of today. Shannon, back to you.
So I'm just going to talk a little bit on the next slide about wellness and what about joy. I like this quote from Don Berwick. We've chosen a calling that invites people who are worried and suffering to share their stories and allows to help. If any work ought to give spiritual satisfaction of the workers, this is it. And I talk about this not again to overshadow the reality, but because it's backed by good science. And we know wellness is just actually one part of this and resilience, but it's a lot to do with QI and creativity and compassion and camaraderie. Those are components of this. So for me, this theory is about culture and performance, and it's tested. So how do we just really ground ourselves in terms of model development in this theory? And I think, again, the conversation about joy, it kind of began as a way to shift the mindset to work with an asset as opposed to managing a deficit, which we, you know, used to call morale, but is so much deeper now in terms of burnout. And we need now to shift the mindset more than ever. And, you know, Stephanie talked a little bit about when we show up with our cute ideas or our new ideas and the eye rolls. And we have to be really careful with this when it comes to joy and work as well, because people aren't so sure that we're going to be able to pull this off and make the changes that are required. So we can go to the next slide, and we're just about done. We've gone a little bit over, so I do apologize. I hope folks are enjoying lunch and things like that as we talk. And this is sort of what Stephanie and I, through actually the work in this presentation, but just some of the research we've been doing and the conversations we've been having with each other, but also with some of you on the call and concerned leaders across the province, really. This is what we're thinking about in terms of moving forward, taking into account what we've learned and continue to learn with a focus on creating a proactive approach to the human health resource crisis to make the best of it, but also, you know, to move into a more positive future. Just a quick nod to Vidge Richards, who some of you know, she's a nurse, a psychotherapist, and an author of Shift Stress. She works in the compassion, fatigue, and burnout space. And if you're looking for a quick read that is helpful, that's one. But I kind of borrowed a bit of her ABC model. And I'll just share with you that my daughter in her first year of fine arts at Western was home yesterday, and she pointed out some flaws in my rudimentary visual. She said, "Mom, people don't read clockwise and R doesn't come after C." And I said, "Well, research starts with R, Grace." She said, "Yes, but data starts with D." So there you go. Anyway, this is our first attempt at what we're looking at and what we'll be taking to our teams in the region to think about as a framework for going forward and continuing to make the best of the environment we're in. So awareness and acknowledgement, again, looking at those critical care surveys, our internal surveys, and learning from folks around the globe and educating people so that they can be aware of their own burnout and so that they can start to participate in the collective and how we're taking care of each other. Balance, both work and life for the individuals and the collective, and a new balanced model. So thinking about our skill sets, knowledge, judgment, expertise, leveraging tech, community members, and non-traditional approaches to critical care. We're thinking that's really important. It seems that I'm so balanced, I've put learn on both top two quadrants. Compassion and commitment. I appreciate, Stephanie, that you're off mute and laughing at my jokes too. It helps me keep going. Compassion and commitment. Really, this is about upstream thinking, joy and work, quadruple aim, and the leader duty to care. It's the soul work. Peer supports, really thinking about those frontline leaders and obviously our teams, and exploring how, shared values come into critical care delivery, and offering opportunities for people to work in an environment in the region where they can live their values. And on research, or as Grace would say, data improvement, always thinking about how we're going to test our models and our tests of change. Being in a place with some small units, we think we've got a good opportunity to do some testing. Critical care leadership development, would love to see more work in that field specifically. And on advocacy, really studying the impact of these initiatives that we've all really benefited from through the workforce recovery work. And eventually we'd like to build out a toolkit for creating healthy critical care workforces. Which takes me to our last slide, which is really the near and far future, and just what we're taking away as next steps, and invite you to think about. I never thought I'd use the words loving kindness on a Critical Care Services Ontario talk, but that's one thing from my own personal leader practice perspective, thinking about early in the day, what am I going to do today out of kindness? A little bit selfish, because back to the science, there is such a thing known as the helper's high, which acts of kindness have a positive effect on the brain. It's transmissible, and loving kindness is actually a critical resilience factor. So invite you to think maybe differently about how you start your day. And then on a broader level, we are looking to build a regional support plan and education for our critical care leaders, and the remodel that Stephanie so passionately talked about. We think we have built the relationships and structures across the region that we could really do something innovative together to care for critical care patients in Waterloo Wellington, with a real focus on improvement, science, and joy in work. And that's it.
Well, ladies, that was fantastic. And I made actually a fair number of notes and things like that. And so we'll go to Crystal and Michelle in just a second here. I do want to say several things resonated with me, and those who've heard me speak before, the care models that we presently use, I really think are dated. So I'd be quite interested to hear, maybe not so much even today, but in the future, about some of the new strategies going forward. As CCSO knows, that's one of the topics I'd like us to explore of critical care 2.0. How are we going to do it post-pandemic? Because the way we did it before certainly wouldn't be there. And it was interesting, you talked about productivity. I always think about staffing to acuity, which is probably somewhat akin to what you said. And I'd also be remiss not to acknowledge your acknowledgement of the critical care managers. Full disclosure, my wife was a critical care manager during COVID. And I think they were some of the lost souls in this, in that weren't recognized for the role that they provided during this, in that unenviable position of reporting to the hospital hierarchy, but also then facing the acute staff. And so thank you for recognizing that. Where I wanted to start, though, was on fostering compassion. And I think far too often now, we always try to practice for patients like this, as opposed to what is best for this patient. And this idea that everyone's interchangeable, that one person can work in any site, I think that's destroyed relationships, but also has impacted compassion in an adverse fashion. So I'm curious to know, what are some of the strategies that have been employed by you to try to improve compassion that providers give, be it nursing, be it other health professionals, even be it physicians. So I'll pass that over to you.
Yeah, and I think, I'm speaking a little bit outside of just the critical care space, but over the past number of years, having worked in different positions and different size hospitals and things like that, for me, really getting to compassion in healthcare, both pre and during and post pandemic, is about the common purpose and bringing people back to why they're here, not, here at the job they're in, but here in healthcare. And it just starts that fire burning around getting back to that, because people really do start this kind of work with some level of desire to care about people. This is for me what hooked me on joy in work. Is this is a compassionate service delivery, and so it's finding ways to get people back to their common purpose. That's one. The second is actually just the basics of relationship building as leaders. And I remember having leaders like this who are out of their way saying, what do you need more or less of for me? How can I help you today? I see that things are hard. I don't have all the answers, but what can we do right now so that you feel heard? And I find that goes a long way, and it really is kind of spreadable. The only other thing I would just say to Dave on the leadership piece, because part of the work that I think many of us are trying to do is help those people feel that what I just described that we're working to give to the clinicians as well. But it's actually the whole frontline leadership teams in critical care too. We talk a lot about managers, but I'm thinking about the educators I've worked with over the years and the resource or charge nurses, and that sort of group of frontline leadership and the weight that they carry home with them every day, and the hours they put in, and just their heart and soul is in it, and their why is strong. So for me, it's really like not doing anything for people without people, and just really supporting that team in the way that I just described. How can I help you? I don't know, Stephanie, if you have something else to add.
Yeah, no, I think, I think you touched on it, and I think it doesn't have to be big, and it can be those small, how can I help you today? This is really difficult. It's showing up in, at difficult times, difficult conversations, families may be in crisis. How do we support? But it's also, it's defining roles and what is your accountability and how do we bring people together? There's so many caveats to try and bring compassion back in, and it goes much further than being fully staffed, because those problems still will escalate. So I think it is showing up and leading with that compassionate sort of view.
I also think there's so much we can learn from positive psychology and some of the social work fields right now around compassion, and it's really making a resurgence. I know lots of folks are Brené Brown fans, and working my way through The Rising Strong, one of her more recent books, and just really thinking about how do you offer people a space to be creative and process what we've been through. I mean, if you think about critical care in the last few years, and I remember the days when we were making decisions, and I know this must weigh heavily on CCSO as well, about what's it going to look like if we need to triage ventilators? Like, have we really given people the space to process how heavy that is, that we got really close to that?
And that we did it, right? And that we were making triage charts to how was that going to happen, and picking a panel, and that's a lot, right? That people did.
That's great. I'm going to go to Crystal next, and I would encourage people to submit questions to Q&A, please. And Crystal.
Thanks, Dave. Thank you very much, Stephanie and Shannon. That was a really great presentation. There was, like Dave, I made a lot of notes already. There were as many things that resonated right off the top as the kindness and compassion, which I think throughout the majority of the people that are interested in critical care and caring for people, it really came in and believed that could solve the majority of the problems that we encountered, no matter what it was. So I really appreciate the focus back on that, because fighting all the fires, we've moved away from that. Some of the other things that really struck home were the being nimble, the team building, and joy and work as an asset. I really like focusing on the positive and building that, and not focusing on the deficit and the negative. One of the questions that's come up from the group, a little bit similar to compassion, but is about wellness for frontline staff, is, are there any current wellness initiatives or strategies that you're using in the region that you've seen be effective with the team?
I can start, Shannon. I think, each organization has done a lot of wellness focus for sure. One of the things that we heard out of our ICU, and I know our directors on this call today, was about additional supports for mental health. And, that certainly was awarded to all hospitals across the province. And I think that that was very welcome from even with that first responder view, we knew that police and fire were receiving it. And we really needed hospitals to receive at least some level of support. I think the peer support model has been really, really effective. We have an emergency department in our area that has a very active WhatsApp group from a peer support perspective that are using that for situations that arise that may be less than ideal, and how do they support each other. And in our ICU here at Cambridge, I know the physician and the staff are working through what that model can look like for them. That's definitely been one. I think, when we talk about different things around creativity, and we've heard from many of our staff that journaling, different things like that has really opened up some sort of those creative outlets. That's helped. Shannon, I'm not sure if you have anything to add to that.
No, the only other thing I would add, and I've just been back in this region, as I said, since September, but I've been in and out of critical care spaces. One thing I've seen here, and I know our directors on the line here too, I think that I've seen bring some wellness and positivity to the critical care team is really teamwork and participative leadership. So just those huddles, being together, lots and lots of communication, and really celebrating. The other day, I'm thinking of a huddle I was at where there was 4, which in a 12-bed level 3 ICU, 4 new staff, all starting their internship after their critical care academic rotation, and it was celebrating. People are really happy to see new people join the team, and that teamwork piece is going a long way to wellness. That this unit at Guelph has had some loss also, and I just really saw how people came together around each other to support each other, and that teamwork is really feeding into their wellness, I think. Now, having said that, our scores on the burnout, and this is sobering for us. Our people are telling us they're burnt out and tired, and we're still, we haven't nailed it. We don't have the magic wand on wellness for sure, but those are little things that I find hopeful.
This, I guess, is kind of a bit of wellness, but not really. But I think I would be remiss if I didn't thank Frank Reinders, who is our physician lead, and he's very committed to us. And it is one text from any of us to Frank, and he immediately mobilizes support. And he speaks that language to other intensivists within the region, and he has really, really committed to the group, and has really been a valuable member of support for us.
Thank you.
Well, that's good to hear about Frank. Hopefully he's watching, or certainly I can pass it on to him. One of the comments that was sent to me was discussing about the importance of empathy, and I agree completely with the listener about, it's not just sympathy, it's not just compassion, it's having that empathetic response, be it with their colleagues, be it with friends and family of patients and the patients themselves. And so I'd be remiss not to pass that on to you both. I don't know if you have any comments on that, or how can you not agree with the importance of empathy with that. Michelle, I was wondering if you had any questions for Stephanie and Shannon.
I do. Thank you both very much for such a great presentation. I think that you've given the whole group a lot of takeaways to think about, regardless of the size of their organization. Like you said, I think it can apply to the rural hospital right the way up to the large tertiary teaching center. You introduced the idea of a code lavender in your presentation, and just a question regarding what behaviors would trigger this code, and then what would the response be?
I can start, Shannon. We've been in a situation where, maybe a nursing assignment isn't to be as expected, or we were floating people into an ICU or floating people out of an ICU. And the reaction to that has been, you can tell that the staff member is not their best self and they are completely overwhelmed. And whether that be in anger or frustration or tears, and it is that, you know, what can we do for you? We can see that you're in crisis and you need some support. And, you know, we're starting to see evidence of that across, and this is outside of critical care as well. And I think if we look at a view of empathy and kindness and compassion, some people don't know how to put their hand up and ask for that support, but this is something that we can offer them and take it away, even if they can just get a touch point initially and try and move them out into a safe space that they can get the support that they need.
I think there's some, I don't know if anyone on the line or put something in the chat. We haven't moved in this direction at Guelph, and I know, but I'm curious if anyone has implemented the Code Lavender. I don't know a lot about it yet, to be honest. And actually, as I said during our talk, it was a moment for me that I do think that leaders come to work and hope that nobody's burnout is so bad today that they have to go home. Shift, you know? So, but I think there's some people doing this maybe. I put also in the chat Simon Sinek YouTube. It's like a 20-minute listen on understanding empathy that, again, for me is about switching the mindset. That's a helpful listen a colleague had passed along.
That's great. Before I go back to Crystal for a final question from her and then from Michelle, I would remind all our listeners if they could fill out the survey that will be posted shortly. That's helpful for us in going forward. One of the last questions I have is, are there any ideas or differences for other health professionals? I know that by sheer numbers, we focus on nursing, but I think we'd be remiss not to think of the various therapists, be it physio or occupational therapists or respiratory therapists, even pharmacy and even our health aides. Any ideas or how you approach them differently, or are they somewhat similar to your nursing team?
For us, oh, sorry, you want to go,
No,
Shannon?
Go ahead, Stephanie.
I think for us, you see both of us just to interrupt each other all the time and just talk. But for us, it is a team. And there are most days we don't differentiate between nurse, respiratory therapist, physio, clinical aid, whatever it may be. We try to create a very, very cohesive team. And I think that you would see that across all critical care units in WW. Even at our critical care meeting, we just don't talk about nurses. It's if you don't have as many RTs, what is it that we're going to do if we have to smooth and move vents or whatever it is? It really is, the focus is on the team, not a specific discipline.
Yeah, the only thing I would add is I do think because nursing is the largest percentage of human resources in any hospital and acute care, that it does sometimes, some of the nuances of making changes and having real shortages there around labor relations really can steamroll other disciplines. Like the conversations can make it seem that it's overemphasis on nursing. I think Stephanie's right. It's really about moving towards people, and that's part of the compassion and kindness move is thinking about people as part of the team and humans, not as like the person who fills this assignment today. It's really part of my desire to get away from just conversation around ratios and but really like what do our whole teams need to care for a patient in a way that, you know, doesn't leave them feeling burnt out and overrun. So it's about a collaborative team approach, right? It's the collaborative care model as opposed to primary nursing, right? Like it's sort of shifting our focus in that direction. And I would say it's probably going to require a shift at the provincial tables too, to just make sure we're talking about it. There's shortages with everyone, like I look at our colleagues in the lab just trying to keep the lights on, and in lots of places with lab techs, for example. It's a struggle. And I think if you feel unseen in that struggle, it's probably even harder. It goes back again to just really knowing people in your building, and even showing your support by asking, things are really hard. Is there anything I can do to help? I think when you ask the question, how can I help? And I didn't come up with this. This is, I think, a Cy Wakeman thing. But when you ask the question, how can I help? It really does shift people into a different mode of thinking. Like sometimes I think we're approached often with, burnout. What I've seen can show up as ticked offness. That was a quick censor on my part, but and sometimes if you just take a minute and say, like, how can I help? It can toggle people to a different space. And I've seen that work. And it's kind of like, how do we teach our teams to do that too? I think many of us have been working on our culture around floating, moving people around all over the hospital, big and small. That's a big stressor. I've seen that in all levels of organizations. When you have to float to a different team, because team is important, it's stressful. And it's really teaching people to receive a person into the department with a how can I help, and to go to a department with that sort of script of how can I help. And next thing we'll just have people fighting about how to help each other. I wish it was that simple.
No. Asking is, especially when someone is upset or angry, it's hard to say in that emotion when you have to think to answer. So excellent advice. Crystal, a final question for our speakers?
Yeah, thank you. Similar along a question that came up is you provided some great examples for wellness, and this is along the importance of team. Have you had some great success with specific team building exercises, given the challenge of the pandemic or, different centers?
Yeah, the traditional things of going bowling or doing those things, the pandemic has certainly, we've not been able to do that. And, for many people on the call, ICU Christmas parties are generally legendary, right? And and it's something that people really have missed. It's something as simple as, I think the picture I showed, they had the Cambridge team had their green shirts on, and it was an award they got for organ donation, and it's taking those really small things and trying to celebrate them. And it's just showing up. And we have a great director, April, who's on, who really does take sort of taking care of her team to the next level. And it's celebrating very, very small things. We've tried to do things organizationally just to offer a little bit of joy, but it really is more about how do we get creative to do that.
Stephanie, I would also say people should check out the Cambridge Memorial Instagram, because there's always something uplifting happening on wellness in that hospital. I would say, with the wellness dog, and
yeah, we have a facility dog for staff, not for patients.
Yeah.
And if there is a crisis, generally, if there was a crisis in ICU, Ember is part of the response for that. And, we've seen intensivists lying down on the floor talking to the dog after something that's been critical. And it's been remarkable, really. And our commitment about debriefing and different things like that. But we have a great team. So we're very proud of that.
Thank you.
That's great. Thanks, Crystal. And I'm glad everyone else has a dog. We have 2 dogs, and I love when you look at their pass, that they have their hospital pass with their picture on it. So so that's good. And I'm glad that your parties are as good as ours. One of my proudest moments was as a department head was the fact when we had a noise complaint about our Christmas party. That's legendary. A joy for me. I'll go to Michelle and then for some final comments afterwards.
So I agree that a lot of organizations are really good at dealing with crisis management and the whole debriefing process, like you just mentioned, Stephanie. But when you're not in the midst of a crisis, how do you get the team focused on their common purpose? What are some strategies that you would use just in the everyday to get everybody centered on what their purpose in healthcare is?
That's where I think going back to, I know it's been out there for a while, but the IHI document on joy in work really offers some great advice on how to do that, and to start with purpose and then start working your way towards what are the pebbles in your shoe, and start to, you'll get boulders. It says that right in the document. It's like a warning. You're going to ask and you're going to get the big thing you can't lift. But there's also advice there on how to manage that. And why I go back to that document is several roles ago, I worked in 2 tiny hospitals in the Southwest, and we really realized that engagement and joy in work was an issue. And we put it on our QUIP for 3 years. And I laugh because we used to come together in the Joy in Work committee, and we sometimes called it the Joyless committee, because there's actually really hard things when you start getting to the root of common purpose and pebbles in your shoes. So I think it's about, again, like future thinking. How are we training our leaders to do this work? How are we going back to the science on, building out resilient teams? I had the privilege of working through the pandemic with a large number of medicine teams, and you can actually see teams that went into the pandemic with a certain culture and had done some work around teamwork and common purpose. And I'm looking at Shelley Petruskevich because we were colleagues in that time, but you could really see how people coped differently depending on how that culture had been fostered in advance. So I think it's really, I don't know, Stephanie, maybe you do have it, but I don't think you would walk into our critical care units in Waterloo, Wellington and say, oh, they've obviously conquered burnout. I think for us, this is a lot about future thinking and getting back to culture and kindness and really like rethinking the model of care. And those 2 things for me are really tied hand in hand.
I would agree.
So I don't know if
Yeah.
that was a good answer, but it's the only one.
It was. Thank you.
Well, ladies, I think time is our enemy, and unfortunately, we're up against the end. Those who may not be aware about IHI, it's the Institute for Healthcare Improvement, and we had fun going to the Orlando conference when we were going to conference, and hopefully we can do that again sometime in the near future. So thank you both for taking the time for such an interactive and informative presentation. I would ask all our listeners to please fill out the survey when they have a chance. It does help us moving things forward. I want to thank again the CCSO team for all they do to make these hopefully a success for everyone is what I think they are. And I know it takes a lot of time and effort. So thank you, everyone. And our next OC3PR coming up on May 11th is the start of 2 things that we're doing. One, we're going to start with the history of critical care units and the care that's provided. And then we're going to follow up with some of the things that were alluded to in the presentation and hopefully in where we're going forward and how we can do critical care 2.0 or whatever version you want to call it or however you want to describe it. So thank you, everyone. Thank you, CCSO, and thanks again, Stephanie and Shannon, for an excellent presentation.
Thanks for having us. Much appreciated.
Thank you.